Regulation is a tricky word because I'd have to say in the United States there are definitely standards of care, there are best practices, which I want to touch on, but there's actually very little actual federal or regulation involved. I think as a consumer that might make you a little uncomfortable, but there are actually ways of identifying which clinics have best practices through organizations that are voluntary, reporting like SART.org, where pregnancy rates are listed. And honestly, the thing that you have, the Men Having Babies survey and related consumer-driven surveys, I would have to believe are probably the most authentic ways to gather information. The FDA in our government does regulate one aspect of surrogacy. It's very limited. It has to do with infectious diseases, and there are some rules that are actually enforced that mandate that certain infectious diseases have to have been demonstrated to be absent at certain time frames in the process for anyone involved in the production of embryos, so be your egg donor and you, if you're using your sperm partner, or a sperm donor if you're using sperm donor. But the concept is simply to protect the surrogate from the potential transmission of an infection of a certain nature that the FDA has a list of. So that's something, but it certainly leaves wide open some of the other practice patterns and issues. The point of surrogacy, as I hope everyone learned today, if you didn't already know it, is to maximize efficiency and success and safety while minimizing risk. I'm sure there's been a lot of discussion about single embryo transfer, and one of the most risk-associated decisions that each of you will likely make is whether to go for a twin pregnancy or by putting in 2 embryos and really roll the dice there. And it's really important that not only the associated risks of preterm delivery and a few other things are clear, but that when we screen the surrogate medically, that we do it in as precise a way as possible. So the agencies that I feel are doing the most outstanding work are those that partner with clinics and not just hand a file over and say, is this a go, is this a green light, can we use her, is she good? But rather have a dialogue well before you even are introduced into the matching scenario that goes something like, this is a surrogate who's, of course, her medical history, her obstetrical history, all the resources and supports around her, but also this is a potential match to a single or a couple who are thinking about twins. Do you process her? We process her in a way that's more precise, that measures her uterine volume. There's certain predictors of preterm birth. I think like they say in the financial industry, the best predictor of future performance is something like the past, whatever. It's not that different in upsetting. When you look at a medical record and see the surrogate applicant who's had 3 or 4 great, healthy, big 8-9 pound babies, and there were no preterm births, you probably want to associate her more with a potential twin pregnancy than you would with somebody whose uterus. When we measure her, one of the tests we do in the office measures with either an ultrasound or a hysteroscope the volume of the uterine cavity. There are some people that we would green light, if you will, for a single embryo transfer only. So again, that goes back to risk. It's not completely only about helping you accomplish your goals. It's also doing it in a context that's safe and safeguards the surrogate. So there's certain predictors and risk factors. There's obviously blood tests. There's I don't think things that would surprise any of you, but I think the context of the match is really an important part of introducing you to someone whose trajectory is aligned with the one that you envision. Egg donors are screened in different ways. We're not at all concerned with previous obstetrical history, which probably often not one, because these are commonly 22, 23-year-old women who are doing great things in their lives that don't include yet having babies. So there's a completely different way to screen egg donors for the same infectious diseases and all that. And I think best practices vary, and I'm not sure I can say that the way my clinic does it is the best practice, but the way we do non-anonymous donations pretty much only. We don't require people to meet their donor, but we strongly encourage it, and our donor pool is extremely oriented from the beginning to have some type of interaction with the person to whom they're donating. They all have little videos, and so we thought, I mean, as a gay dad or anybody who's going through the process that's going to need to have some pretty authentic conversations with their child, their children later on, that there's a part of that process that includes knowing aspects of the egg donor that's not just on a page or in an anonymous setting. I think the standard in the United States, if I were to say what's more commonly, that's probably more common to not do that. But I think that when you look at how you choose your egg donor, you want to look at how transparent is this? Do I get to at least see her first on a video, and then you get to take that to the next step and Skype with and meet with. And obviously, for some people, that opens the door to future contact, which you're never going to have if you start out anonymously. And even if you start out openly, you still may not have. It's completely up to you and your donor. Some of my families really, part of their donor matching involves a relatively high priority placed on the relative likelihood that egg donor is open to meeting your child someday later on. So it's both short-term and long-term thinking. But I think that the transparency of the egg donation process is evolved a lot in the United States. I'm pretty proud of the way a lot of the clinics are starting to do that. As far as the question about embryo transfer,
I'm going to ask you to zip through that one real fast.
yeah, I mean, there's risks to putting in two embryos regardless of whether they both come from the same dad or one from each, but I would say the most common thing to do is a two embryo transfer, one embryo from one dad, the other from the other. You're 84 to 90% likely to achieve a pregnancy, but the majority of those pregnancies are twins, and the twin pregnancy trajectory has to be really discussed from the beginning from multiple perspectives. But I'd say, yeah, sure, couples always one embryo from each dad. All the twins you saw walking around here probably were fraternal twins, most likely from each dad.
Thank you.
Thank you.
Okay, let's. Are there any significant differences in the screening process and the medical issues? Dr. Clifford Librach is going to tell us about Canada.
Okay, so I'll try to be as brief as I can. We are highly regulated, actually, in Canada. We're regulated both at the state, or as we call it, provincial level, and at the federal level. We go through inspections of our ultrasound procedures, our sedation procedures, and our IVF procedures on a regular basis. In fact, I can't even think of a time we're not preparing for the next inspection that we're going to have. And we also, most of the clinics in Canada go through a voluntary accreditation system, so that they come and inspect and give us advice for how to improve our processes, which everybody can improve what they're doing. Also, we have recording of all of our statistics through a central agency, and we actually look at all the statistics and we see if there are outliers. And I'm on a committee called the IVF Improvement Committee in Canada. We're good to each other. In other words, we help clinics that are struggling to try to improve their statistics so that we all provide the best possible care to the patients that we look after. So we're sort of more of a group effort in terms of helping patients to achieve their goal of having a baby, which is very unique in the world, actually. Surrogates are screened medically through initially questionnaires. We have to make sure, of course, that they're obviously healthy and that they've had healthy births and that they've had a birth before. They must always have had a pregnancy before that was not complicated. We get their records. We always see surrogates in our office if it's possible. There are some that it's just a far distance to travel, and then we get a good medical person who's qualified to take a look after, to assess them, to give us their report on that patient and that surrogate. We also get blood testing, ultrasound testing of their uterus, and very similar to what Dr. Doyle has said. We really want to make sure, because we're looking after you guys to have your child, we're looking after your egg donor, your surrogate. We want to make sure everybody comes out of this in a healthy way with a healthy baby or babies. What safeguards are used to assure the health of care? If they're local surrogates, we look after them through their first trimester right in our own clinic, and then we refer them to one of the better obstetricians that we can find to look after them, or midwives. And also, if they're further away from the clinic, we always try to find the best possible medical person to look after them, who's often had experience with surrogacy, because I think that's an important thing, to have experience with surrogacy and looking after the special needs that are involved in that type of way of building your family. Egg donors are identified through agencies, and we refer many of our patients through egg helpers who are here today. If people can't find a donor, they have many great donors. Through them, we will work with several other agencies that are out there that are quite well known. I won't go through the details of who they are, but we can refer you to them. The egg donors are screened. They come to our clinic. We do a full medical assessment, physical examinations, blood testing, genetic testing, basically all of the similar things that are done, as Dr. Doyle mentioned. They mostly come locally, so they won't have high costs of travel from more distant places, but some of the donors do come from further afar. The information about egg donors, I usually say you get more information about them than you probably knew about your partner when you got together. So the detail is quite a lot. You get at least 20 pages of information with pictures and so on. And the donors can be known or anonymous. It's up to you. If they're anonymous, what that means is they have also the choice that some donors want to remain anonymous, or you want to do it in an anonymous way, but they have a choice of meeting the child after 18. If the child would like to meet them, they can be open to that or not open to that. It's about a 50-50 split for those anonymous donors, whether they're willing to meet the child after 18 when there's no parental legal support responsibilities for that child, and it's an adult and they can now decide what they'd like to do. And then IPs, of course, if it's a known situation, would obviously meet them. The embryos, we obviously, the safest option is to transfer one embryo to have one healthy baby at a time, but we do allow for twin pregnancies or put in 2 embryos. We won't usually put more than 2 embryos in very rare cases, but usually almost always 2 is a maximum, and then there's a chance of twins, but obviously the surrogate has to agree to the increased risk for her of having twins, as well as you've just heard about the risk to the baby as well. So we, obviously the preference is always 1 at a time, but some people have a very strong desire to have twins, 1 from each couple, and we will definitely accommodate that if they wish to do that.
Thank you. Sergio, can you give us the 3-minute version of Mexican medical requirements?
Fertility centers are regulated by the Federal Commission for Sanitary Risk. They issue a permit, and they monitor and verify our protocol and procedures. And this permit should be refrained every 6 months. That's how we are regulated in Mexico as for fertility centers. Our surrogate mothers, of course, are screened, and are screened in 3 different levels. They're screened, of course, medical, social, and psychological. Medical, because we have to ensure that she's got proven pregnancy, she's fit and healthy to carry a child, or 2 child depending. And the social screening is because our surrogates, unlike other countries like Nepal or India or Thailand, where surrogates were allocated into specific facilities during the pregnancy in Mexico, our surrogates live with their own family. We choose surrogates that are single moms. This is due to our policies, the policies of our clinic and agency. We want to benefit single moms. And that's why we select single moms to become a surrogate mom as well. It's very easy because we ensure that she's got proven pregnancy, she has either already a healthy child. In order to become a surrogate mother, she must have at least 1 kid under 10 years old. What are the safeguards taken to assure the health of the carrier? Well, like I said, we screen the surrogate mother, and we assign a nutriologist. And our surrogate mother is of a mid-class level. This is because we select someone from the mid-class level because we don't want her to have any nutritional issue, because she will have to carry a boy during 9 months. A baby during 9 months. And the health of the carrier is ensured by all the different medical appointments that she will have to attend during the pregnancy. During the first trimester, the reports and the medical reports are sent to the IPs every 2 weeks. In case of twins, it is considered a high-risk pregnancy, and the reports and the medical appointments will be
carry out every 15 days during the whole pregnancy period. We have many different joint ventures with different parties, such as egg banks in the US, international agencies, international egg donation agencies across the world, and of course we have a local bank. All the donation, any donation in Mexico is anonymous. You can have lots of information about your donor, but you will never have access to any personal information. You can have clinic information, medical information about the donors, photographs are available, and you can have information about their parents, their grandparents, but you will never have access to personal information. As well, if you want to contact your donor when your kid turns 18 years old, that unfortunately is not allowed in Mexico. Otherwise, what you can do is, if you choose an international donor instead of a local donor, then you can ask your donor if she would like to meet her offspring in the years to come. But that's very unlikely to happen, at least in Mexico, due to the law. And us, in our clinic, as per medical protocol, we always transfer to embryos. This is to double the possibilities of achieving a positive pregnancy, but we cannot transfer two different embryos from two different men onto one surrogate mother. This is, by law indications, is completely forbidden. And if you want to transfer these embryos from different men, you have to do it by independent procedures. You have to have a surrogate mother for your own genetic material, and for the other that another surrogate mother will be needed to perform surrogacy. So what we cannot do is to transfer two different embryos from two different men onto a surrogate mother. That is not allowed in Mexico so far.
Thank you. I'm gonna change the format just a little bit. I want to do a sort of a speed dating answer because I want to get some question and answers in. For Diane, Cindy, and Sergio, if you could give me your 1-minute answer on how you facilitate the relationship with the IPs and the surrogate mother, what you do to help the intended parents create that relationship and maintain it, if so, after birth, and also if you could add into that component of just a brief discussion of what the fees are in the different countries. Yes, yeah, no, I'm combining the last two. I'm going to get into the medical that also. No, the fees for the whole process, but the relationship during and after, yeah.
Okay, so what happens is a case manager is assigned both to the surrogate and to the intended parent. And so that's the case manager will facilitate that relationship, will suggest Skyping once a week, will facilitate the contact. And by having the case manager be there, you, as the parents, always get to be her cheerleader. You're never the bad cop. If you're worried about something, then the case manager steps in, and the case manager will take on that worrisome conversation. We'll deal with the money issue. The case manager will deal with anything like that. So the case manager doesn't get in the way, but we facilitate that good relationship. We want you to have as much contact as possible and facilitate that good relationship. And then after birth, we don't want the contact to stop, because think about it, she's been the star of the show forever. For the last 9 months, certainly, usually for the last year and a half, but it will develop organically. And so she wants to see pictures of the baby, but it's not usually contractual. It's something that develops as it goes. I mean, we have one of our surrogates here today, and her parents are coming, and it just, it will develop organically. With respect to the costs, the agency costs are we try to do fixed costs. We do fixed costs so that you know what the agency costs are. Then what happens, will depend on what clinic you choose. The way we find out what your overall costs are is we ask our parents, we keep spreadsheets at the end. Okay, what did that cost you? And what our parents tell us is that typically a journey costs about $125,000 to $135,000.
In Canada, there are a few agencies that help manage the journey. The one that's here today probably has the most extensive case management program with the number of staff involved. The surrogate has a staff member from the agency who helps her go through the journey. The parents have people from the agency that help them. In addition to that, the role of the lawyer is to set out the contractual obligations. So legally, the contract will say that the parents become the legal guardians, the custodians. They have all social rights to their parents, and any relationship that is to continue is solely at their discretion. But what happens is that this relationship does develop beautifully, and people do stay in touch as they want to. Whether they want to or not is up to them. And when you're choosing the surrogate at the beginning of the process, it's important to feel comfortable with what you think you want in that relationship and choose a surrogate who will share the same values as you. So some people do want very little contact, and they'll find a surrogate who's happy with that. Others want a lot of contact. At the other extreme, you can have that. Because I've been through it, I find that I do spend a lot of time helping with that as well, but it's not necessarily the legal person's role. It's the agency. In terms of costs, I can tell you that the legals for egg donor and surrogacy contract for both lawyers, because donor and surrogate have a lawyer, as well as the parentage application, will cost about 10,000 Canadian, which is very good for you. So I think roughly about $70,000 Canadian for the entire process is a fair number.
Thank you. And we're gonna have the budgeting section in here also, so we'll be able to talk more specifically about medical costs. I want to hear from Sergio and briefly from Dr. Doyle and Dr. Librach about the medical costs. But Sergio, can you tell us about relationship facilitation and the costs in Mexico?
Well, the relationship between the intended parents and the surrogate mother is more up to, it's a decision that is more up to the intended parents. There are intended parents who want to have an active communication with the surrogate mother. Some others, they don't want to really meet her. Like I said, surrogacy is available only in the state of Tabasco. So for signing the contract with the surrogate mother, you will meet your surrogate mother in a public library, where you will sign the surrogate mother agreement. This is a good time to get acquainted with the surrogate mother, to exchange phone or email or Skype account. It's more up to the surrogate mother if she wants to establish as well a frequent communication with the intended parent. She's a human being, and we cannot force her to do something that is against her will. So it's like something that will develop organically. Honestly, at our agency, we do not encourage that intended parents and surrogate mothers should have a very close relationship. This is because intended parents are in a very emotional journey, and some misunderstandings can take place, such as intended parents will become very invasive on the privacy of the surrogate mother, and as well, the surrogate mother can ask for an extra compensation, or maybe can ask for a gift, things like that. You know, the surrogacy journey is not a short journey. It's complicated. So why should we add more complications to something that is very sensitive? We have two programs in terms of budgeting. We have two programs. We have a regular programs where intended parents are expected to use their own genetic material. That ranges from $43,000 for $100 US. This does not include egg donation. We have a warranty program that comes with a set of 10 eggs. And the aim of this program is to ensure a positive pregnancy. And this is a very comprehensive program. And it's about $43,500 US.